Thank you, everyone. Welcome. It's an honor to be here to chat with all of you guys and talk about a topic that I think is important in evaluating patients from a spine perspective. Danielle and I see this a lot, and we think that it's a area of the neurologic assessment, particularly evaluation of these patients, that's really important.
Absolutely. Today, we want to address the comprehensive spine exam. We know that not everyone is an expert in the spine, but a lot of you are referring to us and calling us with questions, or should I get imaging? Should I not? Does this person need surgery? Does this person not need surgery? And so we wanted to go over some of the basic nuances of the exam. It's difficult, and we want you to know what's important. And when you're calling us and asking questions or consulting us, we have some common questions that you might ask us, and then the answers that we're going to be looking for.
Awesome. Well, we hope it's comprehensive. We don't have any disclosures, Danielle and I. Just some objectives. Understand the proper ways to image spine pathology, and really focus on anatomy, right? Like how before we even talk about evaluating patients, with spine conditions, we have to understand the basic anatomy. Also understanding how to perform a comprehensive spine exam is certainly the topic, but we'll sort of go into some nuances and some tips along the way. So hopefully for those that are not in neurosurgery, orthopedic spine surgery can feel comfortable evaluating these patients.
Yeah, absolutely. And there are some red flags that you don't want to miss. If you're seeing a patient in your office or in the ER, we'll go over a few things that you should never ignore.
So some basic anatomy review, right? So we're all pretty comfortable with the components of the spinal column, but really our cervical, thoracic, lumbar, and then sacral segments are all sort of working in unison, like Dr. McKenzie was saying, right? The spine is at a dynamic part of the body, and it's not a fixed segment. So really, what we're talking about is identifying each segment as a mobile, sort of the biomechanics associated with each are important to recognize.
Yes, of course. And so each area of the spine has, different characteristics and different functions. In general, we just wanted to review the very basics. Cervical spine, there's 7 vertebrae, but remember, in the cervical spine, the nerve root actually exits over top of the vertebral body, and so you get a C8 nerve root, right. And that's, I think, a nuance that sometimes people forget about. There's not a C8 vertebral body, but there is a C8 nerve root. The neck is really the most mobile portion of our spine, and this is where we see a lot of degenerative changes. So things to think about.
The thoracic spine, certainly very important. Now these nerves are sensory only, right? So we sort of talk about if patients have significant disc herniations in the thoracic spine, we're expecting a sensory issue, right? Thoracic radiculopathy. And what does that really mean? And we'll sort of talk about some of that briefly, but 12 segments of the thoracic spine, and you can see where the nerves exit there.
And then the lumbar spine, there's 5 lumbar vertebrae, and just make note of the spinal cord. The spinal cord, the conus medullaris, the end of the spinal cord, typically in most patients is around L1. So when you're looking at problems below that, you have to remember, the spinal cord's not there anymore, but you do have the cauda equina. And so just some important anatomy points that we wanted to review.
Right. And when you're explaining this to patients, right, like they're not going to know what your conus medullaris is. They're not going to really understand like where our sacral nerve roots are, lumbar nerve roots, but really, using some sort of analogy that works for everyone. I use the spaghetti and water type of situation is how your cauda equina is sort of free floating in its thecal sac. So and understanding also that there's no spinal cord tissue down there, right? So we're not evaluating somebody with spinal cord compression, but it's cauda equina compression or potentially conal compression. And then in your sacrum, which is a fused segment, there are sacral nerve roots that are very important for innervation of your bladder, your bowel, and then the coccygeal segment at the end.
So C1 and C2, the atlas and the axis, they're just a little bit different than the rest of the spine. Just wanted to throw a quick picture up. C1 and C2, they interlock. The dens slides up into C1. And there's a transverse ligament there. This is your primary ability to turn your head,
this motion. Mm-hmm.
Left to right. Looks a lot different than the rest of the spine. And problems there are treated a little bit differently than the rest of the spine.
And then looking at sort of the elements of the curvature of the spine, when we sort of talk about and look at imaging, we're evaluating patients, it's one of the first things that we see about their spine. And there are normal curvatures that we have to appreciate, particularly in the cervical and lumbar spine, which has a lordotic, right? It's this sort of this type of curve, as opposed to your thoracic spine, which is normally kyphotic. And when we start to see abnormalities of those spinal curvatures, that is a ictus for pain, right? It can cause a lot of problems for patients. So recognizing that the spine curvature may be a source of pathology is going to be important.
Yeah, and you can see from this illustration that there are differences in the cervical, thoracic, and lumbar. We're not going to go into all of the details, but as you get lower in the spine, the vertebral body gets larger. That's bearing a lot of the weight of your body. And so you have different problems based on location, based on what that part of the spine is primarily responsible for.
Yeah, super easy to get cervical fractures, smaller bones, a lot harder to get lumbar fractures. So think, taking a lot more force to break those bones, particularly in trauma.
Yeah, and the thoracic spine is so well encased, I'd say that's the area of the spine we see the least problems.
So some myotomes, important to recognize. We do have a typo at T8. It's actually T10 is the umbilicus. But really what this is demonstrating is, where may the patient have a sensory level, or where may their sort of muscular deficit lie. And so in each of the colored segments, you can sort of see where the cervical nerves innervate, the thoracic nerves, and then into your lumbar spine, sacral nerves.
Yeah, this is really important. This is a picture you need to keep in mind or take a picture of, because if you're having patients who are having either pain or numbness in a certain distribution, this is going to help us decide who needs surgery. Does the problem that you see on the image actually match the problem that the patient has? There's nothing worse than doing a surgery and not fixing the patient's problem. And so it's important to realize what area of the body, if I have pain that's going down into my foot, but I have a herniated disc at L2, those two things may not correlate. And can we fix it? Sure. But if the patient doesn't get better, then, what's the use? So just keep this in mind. Each level of the spine corresponds to sensory in a different part of the body. And this is very important.
Absolutely. So, big part of our practice is, does the patient have adequate imaging, right? We're evaluating someone with potentially an acute spine condition. What are the first things we're thinking of? Well, does obviously their patient's clinical presentation, their history of why they're coming in or potentially into an office setting or the ER, but really, do they have appropriate imaging? It's sort of a big step.
Yeah, absolutely. So we wanted to frame this presentation in questions that you might be asking yourself, or you might be asking us, or you're looking for the answer to. And so the first question that I'm going to have, if you're referring a patient to me, what kind of imaging do they have? And if you're a provider that's referring to us, you need to know the available types of imaging, what you might have access to, what we might request, and why each is important and helpful in different ways.
Definitely. I think even though we try not to be overly reliant on just an image itself, but we're using it in conjunction to make a clinical decision about where we need to go. So here's some different aspects of imaging, different modalities. So X-ray, very common that Dr. McKenzie was talking about, certainly dynamic X-rays, right? That's the bending and flexion extension views, very helpful to understand if there's any dynamic issues in the spine.
For sure. So as Dr. McKenzie said, if you have a patient that has axial back pain, you might wait 4 or 6 weeks, just see if that pain gets better on its own. You don't have any red flags. It's just back pain. Maybe you don't do anything. But especially outside of a hospital or in a primary care's office, X-ray is going to be not only the first test of choice, but the first test your insurance is going to let you get. And so we start with X-ray. It gives us some good information. Absolutely. We can look at the bones. We can look at the height. We can look at the alignment. And sometimes we'll find a problem just on X-ray. Maybe there's a fracture and that's explaining the patient's pain. So it's helpful. It's limited, but it's a great starting point if someone's having pain.
Definitely. CT, sort of our next modality. What are we thinking, like CT wise? Like when should they be ordering CT?
Yeah, a CAT scan is really helpful. Maybe you have an X-ray the patient has had some conservative measures, they've done some physical therapy, they're taking some medications, or they've had a medrol dose pack, and they're back in your office because they're not feeling better. So CAT scan is an excellent study. It shows us the bones in great detail, and we get this in many different views. So that's one of the advantages over an X-ray, is you can go down axially, sagittally, coronally, and take a look at the spine from many different aspects. And so this is really helpful. I'd say probably the next most common modality that we see is CAT scan.
And so MRI, sort of the really, really important modality that we're using more frequently because of just readily available MRI centers to diagnose acute spine conditions, right? A lot of times MRI is not necessarily your first test. It's not necessarily, and we'll sort of talk about when we're getting that, but MRI is going to be really helpful for patients that have acute neurologic complaints. Anybody that has any weakness, any radiculopathy, right, burning down one arm or one leg, that sciatic-like pain. We're looking at the nerves, we're looking at the soft tissue, and we're looking at if we're above the conus, we're looking at the spinal cord and its relationship to surrounding structures.
Yeah, MRI is so dynamic. You can see the bone, but not as well as the CAT scan. But the imaging of the nerves and the spinal cord is excellent. And this is how we make a lot of our decisions for surgery. I'd say very few patients do not have an MRI if they're going to proceed to surgery. You can see things a lot. The softer tissues, the spinal cord, you can see that a lot better. And so MRI is probably, I'd say, our most used modality, but you don't get there without an X-ray or a CAT scan. And you don't go to surgery without a CAT scan either. So just things to keep in mind. But MRI is a great study, and we probably our most helpful study when we're looking at the spine. And then CT myelogram, this is, as you can see from the image, it is a CAT scan. These are patients who can't get an MRI. They have a pacemaker. They, fractured their femur when they were 7, and they have some sort of rod that's not MRI compatible. And so you still need to image the spinal canal. So you essentially just do a lumbar puncture. You inject dye. You can, wait a little bit, and then it illuminates around the spinal cord. And so it's a really useful study. It's an invasive study, but if you can't get an MRI, it's something that we oftentimes order because, as you can see from the image that's here, it gives you a great perspective of if anything is impinging on the spinal cord. So if you can't get an MRI, CT myelogram is always a great choice.
Yeah, definitely. And look at the difference between what you can see on CT and then almost like an enhanced myelogram study, right? It's very, very different modality. Again, it's invasive, so you have to sort of evaluate if that's going to be the right move for your patient, but can be very, very helpful in diagnosis and treatment.
Absolutely. So when should you get advanced imaging? That's a hard question, and it may be different in different populations. And so you have a patient, they've not responded to your conservative measures, and they still have complaints, especially if they're having radicular complaints, pains going somewhere else. It's into their arms, into their legs. So that's definitely someone you should consider, someone who's failed those conservative type measures. And then fevers. This is a hard one because a lot of people have fevers for a lot of different reasons. But a persistent fever with no explanation, someone who has back or neck pain, particularly people who may be at risk for infection, IV drug abusers, you need to keep that in mind. And advanced imaging might be a little more pressing than somebody who doesn't have that kind of a history.
Definitely. Unexplained weight loss and history of cancer, right? We're trying to figure out, is there an underlying malignancy that we're just not able to make a diagnosis? It's unfortunately, a lot of times the presenting complaint is a neurologic complaint. Yeah. Back pain at night that's not getting any better. They have weight loss. They look cachectic. These are patients that we need to be getting advanced imaging, and X-rays are not going to be sufficient in their initial workup. It's not going to help us make a diagnosis.
Yeah, and trauma guidelines are very clear on the type of imaging that's needed, but that's one of the most common reasons we see advanced imaging. And we certainly sometimes find things that maybe have been there for a long time. Focal neurologic deficit.
It's an important one.
Big one, yeah. You notice someone who has an acute, especially acute or persistent weakness, you need an image. Paresthesia is I would say maybe a little less pressing to get an MRI or an advanced image, but regardless, focal neurologic deficit, definitely start considering an advanced image if you can.
Yeah, and really the sensory issue in a dermatomal pattern, sort of what we showed you earlier, is going to be important because what's causing that, right? It's that compression of a nerve root or potentially bilateral dermatomal pattern that may be something that we have to evaluate with an advanced image. We have a question. What imaging for numbness of fingertips? What do you think?
Well, I think that could be one of many things. We would have to determine if this is something that's coming from a peripheral nerve, if this is something that's coming that we think maybe is central. And so one great study we didn't really mention, I think EMG is great in helping to differentiate where that numbness is coming from. X-ray probably has limited help in fingertip numbness, so I probably choose MRI.
Yeah, I agree. I think MRI would be very helpful.
Cervical spine without contrast.
Yep. Perfect.
All right, so the big question, the question we ask everyone asks us, is the patient weak? This is a hard question to answer, so we're going to help you, help identify some really important things that you should be looking at, because this is often one of the key indicators on if this patient is having an urgent decompression.
Right. Since weakness for us is sort of that red flag. It's a light bulb goes on. We need to figure out what's happening to the patient because this could be a long-lasting deficit. So
muscle strength testing, so important.
Right.
You're calling someone or putting in a consult, and we've never examined the patient. We need to know how strong they are, and we all need to be speaking the same language. Are they moving? Are they full strength? Are they somewhere in between? And so muscle strength testing is graded on a 0 to 5 scale. 5 out of 5 is normal strength. You're asking them to resist your strength. You have basically equal strength. 4 out of 5, the patient's able to move against some resistance, but you're very obviously stronger, and they break with your strength. 3, you can move against gravity, but have no resistance to whoever's examining you.
So like arm comes up, you let it go, and it falls right back down to the bed, or leg.
Yeah. 2 out of 5, they're moving, but not against gravity. So maybe they're sliding their legs across the bed or their arm across their abdomen, but they're not able to break that horizontal plane.
Yeah, so when you take gravity out, if you're examining somebody's arm, you want to take gravity out of the equation completely and they can move fine. That's a classic 2 out of 5. So really removing gravity will give you a good sense of, are you a 2 or are you a 3?
Yeah, and 1 out of 5, you can see movement or muscle contraction. You can see muscle contraction, but they're not moving. They're not able to slide it around even against, without gravity.
Mm-hmm.
And 0 out of 5, you see nothing at all. And so this is really important. It's really helpful for us to understand without looking at the patient how strong they are.
Yeah, I mean, put your hand over the muscle that you're trying to test. Ask the patient this is volitional testing, right? So the patient is actually able to follow commands and do these tests with you. But can you move your arm? And if you just sort of feel a flicker, you don't feel any active movement, that's sort of where we're getting into that 1 out of 5. And those patients may be trying and very frustrated, so you have to sort of reassure them, but at the same time, it's a good way to understand what's their muscle strength.
Absolutely. So when you're testing muscle strength, you're testing by group, and I think that's something that's often lost. When you're maybe evaluating a stroke patient, it's does the right arm move? And for spine, it's a little different. You need to test each muscle group to understand if a particular level of the spine is involved. I could have deltoid weakness, but my hand grip is 5 out of 5, and sometimes that nuance is missed. Or they just say, well, they can't move their whole arm. There's a big difference between moving your whole arm and just having one muscle group that's been affected. And we'll go through this when we do our physical exam, but the upper and lower extremity have numerous different muscle groups that can be tested.
Definitely. Just recognizing that's how we document this as well. So if it looks like hieroglyphics to you, it actually means something. D, T, B all correspond to a different muscle group in the upper extremity. IP, hamstring, Q can be quad for hip flexion. Those, all the sort of common nomenclature that you may see in documentation that we do every day, that's what we're referring to here.
Yeah, absolutely. And this, again, this is really important in helping us decide, does the lesion you see on the image match up with what the patient's complaining of? And that, paired with the sensory exam we talked about earlier, help us make the decision of if the patient will truly benefit from any surgery.
Yep. And EHL, for those of you that are not familiar, that's extensor hallucis longus, right? This is your big toe. So this is it's a little bit busy diagram, but it's really just here for reference for you. What are we talking about when we say each of the cervical nerve roots, where their location may be if they have some level of pathology there, right? So what would I expect if the patient has a disc herniation and it's at C5, right? Where is their pain? Where would I expect a potential sensory deficit? And then on exam, these are the muscles that may be involved that the patient may have weakness.
Yeah, absolutely. Different levels of the spine. So C3, C4 in your patients, they have a disc herniation. They're coming in and saying they have pain into their arm or their arm is weak. Well, those aren't going to correlate. And so you might miss a different problem if you're just going to attribute it to, well, they have changes on their MRI of their cervical spine, must be from that. So again, this is a reference slide. We have one on the next slide that's just the lumbar breakdown as well. Just understanding that each level of the spine controls something different, and failing to test each muscle group, you may miss some of these nuances.
Yep, definitely.
So this is a big question. Is the patient truly weak, or do they have pain-limited weakness? What does that mean? Is the patient not moving because it hurts, or can the patient truly not move? And man, this is hard to differentiate sometimes.
Yeah, definitely. I think, when you go in, we all assume that patients have true neurologic weakness, right? We don't want to go in and just assume that they're just in pain and that's why they're weak. We always assume that it's, true and the patient's trying and they actually can't because they just don't have that ability. But when you're sort of teasing out the difference, it's important to sort of recognize, is the patient experiencing pain at the time of the clinical exam, right? Because that is already blunting. If somebody is holding, they're like curved up, lying on the stretcher, and they don't want to be bothered, that patient may have a very different neurologic exam. Because as you ask them more and more, hey, can you lift your leg? That's an inciter for pain, right? It's definitely going to change things.
It's definitely difficult, but we need to know. And sometimes it's the difference between surgery and not having surgery, or surgery at 2:00 in the morning, or surgery in 2 days. And so it's important to tease out the difference. A lot of encouragement, maybe giving them some pain medications before you examine them if you can. But telling the difference between true weakness and pain-limited weakness is a skill that you should have. Pain-limited, they just don't move it because it's painful. But true neurologic weakness, they cannot move. And that's often a surgical emergency.
Definitely. I mean, I think when you can take gravity out, because to have to overcome gravity at a particular level is difficult in and of itself. And so if the patient's having a lot of pain, if you can raise the arm up, sort of like taking gravity out, and then have them go ahead and flex at your bicep, will that go ahead and elicit full strength? Oh, patient appears to be full strength, but they're having a lot of pain when they do it. We see a lot more of this in the lumbar spine when you're trying to do a leg raise. Patient has flexion at the hip, and that stretches the nerve root. So if they have a large disc herniation, you're going to elicit that pain. But you have to do it in a way that informing the patient, tell them, hey, I'm sorry, I just have to test this and make sure you don't have any weakness. And so allowing them to try on their own, which is the active range of motion. If they're unable to do so because of pain, now we're going to passively range them.
Yeah, and you acknowledge and say, I'm sorry, I know that this is painful, but this is a crucial difference. If you can please work with me. A lot of patients will absolutely try, but acknowledging their pain is helpful too. Does the patient have altered sensation?
Oftentimes, yes. Testing the modalities can be difficult, particularly with patients that have other comorbid issues, diabetic neuropathies, patients that are having other medical issues in the hospital. Oftentimes, spine complaints don't just come by themselves. It's sort of a package deal. And if patients are having an acute issue elsewhere, it may blunt a lot of your sensory exam. But light touch is sort of pretty self-explanatory, right? Can you feel me touching, right? Is sort of the general question that we're asking. Do you feel that is not very accurate? Can you feel something? Does it feel equal on both sides?
Yeah. Light touch is the most, the easiest to use. Everyone can do that without any equipment. The rest, vibration, temperature, proprioception, all very important in helping us locate where the problem might be. But for the general layperson, I think light touch is probably what you're going to have at your fingertips.
Definitely. One thing to point out, proprioception, right? The ability to understand where your limb is in space can be very helpful for patients that have a myelopathy or cord compression, particularly in their cervical spine or thoracic spine, right? So if they have no proprioception, meaning I raise one of your, usually at the joint, so like IP joint of your hand or a big toe, tell them what up and down is, and then ask them to close their eyes, and then we move their joint in a particular way. If they can't understand where they have no proprioception, your suspicion should be going up, that it's not just a peripheral problem. So that's an important thing to recognize. Stereognosis, the ability to identify an object in your hand, right? For patients that maybe you have an extended neurologic exam, and you can say, hey, can you identify a key or something in the patient's hand? We use those for stroke patients, but you can definitely use in spine patients as well.
Next question, is the patient myelopathic?
Good segue.
Yeah, this is really important and something that you should know exists at least. So what is myelopathy?
It's a mystery. What is it, Danielle?
So injury, deficit, or inflammation to the spinal cord due to compression. And there are physical exam findings that should tip you off that this patient might have myelopathy. And if you fail to recognize these, you might miss a lesion that's affecting the spinal cord.
So this is a common thing when we ask, folks, is the patient myelopathic? Well, what sort of signs or symptoms may you be able to elicit that will help guide you to say, yes, that patient definitely has myelopathy, right? So hyperreflexia, you just tap on their knee or at the patellar reflex, and they're like kicking off the bed, right? Hyperreflexia. Hoffman's reflex, what is... First time I'm seeing that.
Yeah, we'll go into that. And I think we have a slide a few down. It's just an abnormal reflex that you'll see in the hand.
Yep.
That's going to tell you there's an upper motor neuron problem.
And clonus, again, another upper motor neuron sign, right? One single stimulus elicits a continuous response, right? So that's usually this beating effect of the feet. When you just sort of flex very quickly at the foot, at the ankle, you get this beating sensation, and that's clonus.
So we could talk all day about the differences between upper and lower motor neurons, but essentially the upper motor neuron is coming from the cerebral cortex. They meet in the anterior horn in the spinal cord, and the lower motor neuron comes out from there. And so differentiating where the lesion is helps you identify how you can fix the problem. And so just some key differences: upper motor neuron, you're going to be hyperreflexic, hypertonic, have a positive Babinski, and a lower motor neuron lesion, you're going to be hyporeflexic, hypotonic, have wasting atrophy, and Babinski will be negative.
So some abnormal reflexes, sort of what we sort of listed to earlier. The Hoffman sign is a abnormal stretch reflex. So you're going to grab the patient, stretch here, and then flick that stretched finger usually, and then you get abnormal flexion at the thumb. That is a positive sign to see that flexion response. Again, stretch reflex pointing to somebody who has cord compression and myelopathy.
Yep. Clonus, as Randy said, rhythmic involuntary muscle contraction, most commonly tested at the ankle. And so this is a great illustration. You hold the patient at their foot, and you jerk their foot up, in this instance, up towards the patient. And you'll see in clonus a rhythmic beats of clonus where the foot is moving on its own, and that's a sign of some upper motor neuron problems.
And then Babinski sign, certainly part of that constellation of upper motor neuron dysfunction. Normal is downgoing. Abnormal is this upgoing toe with flaring of the smaller toes.
So reflexes in general are graded on a scale. We love scales. There's scales for everything. So
another scale.
Graded 0 to 4. And so 0, there's no evidence of contraction. Normal's 2. So that's your baseline. 1, very frequently we'll see in degenerative changes, lumbar stenosis, you might see decreased reflexes, but still present. 3 is hyperreflexic. We refer to them as jumpy. You're tapping on their whatever reflex you're testing, you're tapping and they're jumping, kind of jumping off the bed. And clonus, we just talked about, is the worst and I guess the highest graded response. Just reminder slides, again, reference slides, cervical, and then the next is lumbar. But I think this following slide is most helpful. It's just making reflexes a little bit easier. And so a little rhyme, 1, 2, buckle my shoe. S1, S2 is your Achilles reflex. 3, 4, kick the door. That's your patella. 5, 6, C5 and C6. Pick up sticks, that's your bicep, and triceps, C7, C8, lay them straight. It's basic, but it's really helpful and it helps you remember which levels you're looking at.
Yeah. So is the question that we sort of ask, is there alteration of bladder bowel dysfunction? I think a lot of people document this, but what are we really trying to understand?
Man, this is a tough one
Yeah.
because people have bladder and bowel dysfunction for numerous reasons, and sometimes it's a very gray area. Is this related to some back pain they're having? Is it not? It's difficult to tell. It's an important question, though. The presence of bowel and bladder dysfunction could indicate that there's a lower motor neuron lesion or a neurogenic upper motor neuron lesion problem. But keep in mind that there are other reasons people have retention. Severe pain. When you have severe back pain, it's difficult to relax. And so it's difficult for people to urinate. And that alone may just be a reason that they're retaining. Do they have an enlarged prostate? Do they have a UTI? Are they constipated? So there's a lot of reasons. It's multifactorial, but it's an important piece in the puzzle, I would say.
Yeah, and we sometimes, without even asking the patient, can see on their MRI, on their imaging, bladder is huge. And that's when we're like, hey, has the patient complained of a lot of issues going to the bathroom the last couple of days, and they have spine complaints? Now you're, again, those red flags, right? Your suspicion is high. They have some sort of compressive lesion or compressive pathology.
Yeah, absolutely. I would say, by and large, urinary incontinence is a lot more alarming to me than urinary retention. I wouldn't dismiss either, but new incontinence patients are typically very aware of.
Right.
And they will tell you if they have that problem, and that's a signal to move to advanced imaging quickly.
Definitely. Ask the patient if they're insensate, right? Did you not feel when you had to go to the bathroom, and then it happened? And it's uncomfortable to ask patients, uncomfortable to talk about, but it helps us from the spine surgery perspective. Like, hey, is this something that we have to sort of jump on?
Yeah, I think you'd be surprised how many patients are not going to volunteer that information to you. They're embarrassed. They try to hide it. But if you ask, they'll say, oh yeah, actually, I've been having accidents the past few days, and they don't realize that those two things are related.
Yeah. So we were just going to show you just some brief, spine examination of how we do this on a regular basis. So you're going to ask the patient who's seated. It can be difficult to do it when you're, standing. So have the patient seated or supine. So we're going to test first their deltoids. You're going to have them raise their shoulders up, right? And then this I'm going to press and feel, okay, how strong are they at the deltoid? Again, moving down in those muscle groups, which were what we were talking about before, I'm going to have the patient sort of almost make a muscle for me right in front. And then I'm going to test each individual. So I'm stabilizing at the joint and then have her flex, right? So she's 5 out of 5. I can't break that. She's very strong. I know this in general, but so that's going to be about our 5 out of 5, right? We're equal. I'm going to push away and it's going to test her tricep. So again, stabilizing the proximal joint and then have the patient push. Now I'm only activating the tricep here. I have the patient sort of bring your wrist up, right? Like you're riding like a motorcycle. This is wrist extension. I'm gonna have the patient go ahead and try and resist when I'm pulling here. Again, stabilize the proximal joint and then just test that wrist extension. Have the patient show you 10, spread fingers real wide. These are your intrinsics. Right? Have them just sort of keep your fingers apart while I try and push them together. And obviously this is full strength too. Your fingers are very, very strong. So when patients have intrinsic weakness, a lot of times when patients have chronic myelopathy, their fingers are contracted like this and they have no ability to spread their fingers out like that. And then just finger strength, grip strength. Have the patient grip your fingers really strong. And again, you don't want to put more than 2 fingers in there because you can actually, somebody can break them. So 2 fingers, very, very hard for somebody to break, even the strongest patients, but this is a good way to assess equal strength in general. If you don't have a reflex hammer like I don't, your hand is a good tool. What you want to do is have the patient rest their arm and then sort of feel where the muscle belly is and at that attachment there. is where your biceps reflex is. So I'm going to just, sort of provide that, and I can feel already she's got good normal reflexes. Same thing on the other side. Triceps a little harder. You sort of have to hold the arm and let it dangle. And then I'm just going to tap out here. Same thing with this reflex. And then brachioradialis out here. When the patient's resting, I'm just going to tap there. And the same thing with your patellar reflexes and the Achilles, right? So we're basically going to move this on the side. And then you have the patient just sort of let their leg dangle. You can feel the muscle belly here. And a lot of times that patients have significant hyperreflexia, you can just tap there and they're going to try and kick off the bed. But here's sort of the area for our patellar reflexes. Again, feel where the muscle belly is, and you can elicit a response. Same thing for your Achilles reflex. What you're going to do is hold here. Usually the patient's a little bit more difficult when they're like lying supine, and then you're just going to tap here, and you'll elicit the response by holding the joint. So you'll feel them tap that way. And then clonus the same way, right? Flexion at the ankle. Again, you just sort of relax the joint, and then you flex very quickly. And if you get a beating of that, then that's clonus. Any other exam finding? Obviously, sensation, right? You want to be testing sensation on skin. You don't want to test, can you feel that over like heavy clothing? It's not going to be very accurate. You're not doing anybody any service. And then some of the things, right? Proprioception we talked about, right? Can you understand where your joint is in space? So if I define this is up and this is down, have the patient close their eyes, and then holding to the side, I sort of wiggle, and then you tell me where the joint is. Same thing for a big toe. And then if they have no idea where it is, again, more concerning for some different pathology, potentially in the cervical spine.
Yeah, absolutely. So as you can see, the exam doesn't take all that long, but breaking down each muscle group is incredibly helpful in figuring out where the weakness might be originating. And so it's worth the time. You don't need anything. If you have a reflex hammer, that's great, but you can just use your hand and elicit patellar reflex, the biceps reflex. And so you really don't need any advanced equipment. You just need the patient to be able to be seated. I will add that if you can watch the patient walk, that's really helpful to assess their gait. In the hospital, that's not easy and safe a lot of the times, but if you're seeing the patient in the office, watch how they walk into the room, or have them get down and walk and see what they look like. Are they shuffling? Are they dragging something? All important tips, I think. Definitely.
And so one additional area we wanted to cover is, does the patient need urgent surgery, right? It's a question that we could spend hours talking about, but we sort of wanted a quick overview for, you've done the spine exam, you've elicited that the patient has some acute issue. What do we talk about when we say patient needs a surgery, right?
Yeah, absolutely. And that's kind of the overlying question to all the other questions. Does this patient need something? Is it urgent? And when it is urgent, you don't want to miss that. And the vast majority of times, it is not urgent. But here are some red flags that you really need to look out for to start thinking something major is wrong here. So bladder and bowel incontinence, saddle anesthesia, those are big ones. That's going to be usually straight to the ER if they're not already there, advanced imaging now.
Definitely.
Extremes of age. Someone very, very young. I'm not going to say 50 is old, but people who are very young or a little more advanced in age,
right. You
should pay more attention. A 12-year-old sitting in your office shouldn't be complaining of debilitating back pain. And if that's the case, that would prompt advanced imaging much, much quicker.
Definitely. Most traumas, like we talked about before, an acute traumatic event that's enough to break a bone is potentially enough to cause some neural compression or potential, other injuries to the spine or spinal cord. So think trauma with an acute complaint. We're getting advanced imaging usually pretty quickly.
Yeah, and trauma, keep in mind, does the patient have a distracting injury? That's one of the basic principles of trauma. And so somebody fell and they broke their ankle, and then 2 weeks later their back hurts, and they're 75 and they're osteoporotic. do they have something else going on? Sometimes I think you focus on the most pressing thing in front of you, but in trauma, you might notice things a little bit down the line. So
definitely.
Rapidly progressive deficit. This is huge. Someone who was normal walking last week and now is coming to you in a wheelchair. You need to get some advanced imaging quickly. If they've, progressed, they had back pain 2 years ago, and now they sometimes use a cane. Now they instead of 10 blocks, they could walk 5 blocks, but the time course is a year. That's a little bit different. So anything that's really rapid is a red flag. You should investigate.
Yeah, and just good clinical judgment. I think in most cases, no one's faulting someone for thinking, hey, I have a patient here. I'm concerned of what they look like. I ordered the advanced imaging. Most of the time you've done the work, and now we can sort of evaluate, is this urgent or not? But sound clinical judgments, I think, really the tenet to these patients.
Yeah, and weakness. Never ignore weakness. It's not normal to be weak. And if you're noticing weakness that you think is not pain limited, get an image. It's not normal, and we act quickly. You don't have a lot of time to reverse the compression to save someone's strength.
Definitely. Just some pathologic illustrations here, like what's happening with a herniated disc. You can see in the far right-hand corner, there's disc material that's extruded, and now that disc is herniated and it's compressing and exiting nerve root, right? Classic radiculopathy, burning down one arm in that dermatomal pattern. That is the ictus of pain. It's the herniated disc.
And I don't know if we covered this, but maybe it would be helpful to define radiculopathy. What exactly is a radiculopathy?
Yeah, definitely. So radiculopathy is just compression or pathology of an exiting nerve root anywhere. You could have cervical radiculopathy, thoracic radiculopathy, or lumbar radiculopathy, but either way, it's typically a unilateral dermatomal distribution. I can find the pain with one finger. The patient tells you exactly where it goes. I'm like at the dentist and I get that shock down one side. That is a classic radiculopathy.
Okay, excellent. And then our final slide here, just what's a surgical emergency? Things you might see, things you might have heard. Cauda equina, I think everyone probably knows. Anyone who hears this, anyone in a MRI report, it says anything about the cauda equina, and people get, and rightfully so, a little excited. So cauda equina, in this picture here, there's a disc that's pressing out and completely compressing the cauda equina. And then what does this patient look like? If this patient has new urinary and bowel incontinence, weakness in their legs, this person's going to the operating room right now, no matter what time it is.
Definitely. Along that same line, cord compression, right? Where there's spinal cord tissue, there's a large herniated disc here, in this case in the cervical spine, in the middle image. And you can see that that disc is compressing what's normal caliber spinal cord above and below, right? So that in and of itself, that patient will be classically myelopathic. All of those upper motor neuron signs, potentially upper and lower extremity weakness if it's been going on for a while, or if it just happened and it's hyperacute, they may have both.
Yeah, epidural abscess, we love to hate them, but it is a huge problem that needs to be decompressed quickly if there's a significant collection. So in this illustration on the right, you can see the spinal cord is being squished by an epidural collection, in this case an abscess. That's something that warrants immediate decompression.
Definitely. And then lastly is our sort of jumped facet, right? It's sort of rare, but when we see it in high velocity trauma, the facets get locked onto each other and then you get cord compression acutely. And so these patients may have been normal. They fell from a significant height. They have fractures along the facet. And then now the spine is subluxed and it's not going back. And so they need an emergent surgery to decompress the spinal cord and stabilize the spine.
Yeah, I'd say anything, locked facet, unilateral jump facets, anything like that in a report, you should consult neurosurgery. There's probably some sort of decompression that needs to happen.
Definitely. These are all cringeworthy. As we see them, we're like, oh my goodness, these images, they etch a hole in your mind, but you'll never forget them, when you see them. So
yeah. So I think we'll finish up there, see if there's any questions.
First, there's quite a few comments, and I agree. It's really it's very nice to see and emphasize the importance of a clinical exam, because many of us, And sometimes the neurosurgeons, it doesn't really matter the underlying specialty. We go right to imaging. So it's fantastic. And thank you so much for going through that and emphasizing the importance. Let me ask you a question. Do you have any couple questions here. Do you have any how you can help us if a patient, we're trying to get a patellar reflex and the patient's just can't relax? Is there any way we can help them relax so that we can fool them into not paying attention to assessing the patellar reflex?
It's a great question. It's can be very tense in the office, in the hospital, right? Have the patient close their eyes, have them redirect, turn your head some way. Sometimes people say like sort of focus on holding your hands together and sort of focus on that muscle activity there so that sort of distracts them a little bit.
Yeah, I think distraction.
It can be difficult.
Maybe start talking to them about something else or even start examining them in a different way and come back to it. Make sure their legs are just hanging over the edge. They're not sitting or seated on a ledge.
Yeah.
It's difficult, but I think distraction's probably the best way.
Yeah. Or you're screaming at them, relax, and they can't relax. They're having an issue, right? So it's really just redirecting, and all of that can be very helpful. Any other questions? It's good questions.
If you're looking for structural abnormality, do you think you should get an X-ray, CAT scan, or jump right to an MRI? Obviously, after obtaining the complete neurologic exam.
Another great question. Structural abnormalities, particularly looking at the bones, alignment, looking for any spondylolisthesis, right, movement of one part of the spine on another. CT is a really great modality for that. It's quick. Patients don't have to, it's a 30-second scan, and you can get a lot of information if you're looking for particularly structural issues like deformities of the spine, can be very, very helpful. If you're looking for compression of any neural element, patient has any of those symptoms that we talked about before, an MRI may be the next best choice.
Well, thank you very much. It was wonderful. And that's it it's really all we have time for right now. And can't thank you two enough.
Thank you, guys.
Thanks.